I'm ready. I'm ready. I'm ready.
Hello, everyone. Welcome back to Hot Seat Season 3. I'm Omid Moghaddas joining you from Tehran. And once again, I'm thankful to have the chance to be with you all from this educational platform with leaders and best educators from around the world that I'm so honored to call them my friends and that they accepted the invitation and are joining us and they're sharing what they know and helping us to obtain better knowledge and understanding in treating our patients and have a long-term stability for the outcome that we're going to gain. And today I have a very dear friend and gentleman, one of the true educators and active influencers in the field of perio and implant. Dr. Alberto Miselli is here with me from Caracas, Venezuela. Hello, Alberto, and welcome to Hot Seat, my friend.
Hello, everybody. Hello, my friend. Thank you for your invitation. It's a very good honor to share this screen with many excellent professionals that I saw all the video in your YouTube page, and I want to congratulate to you because you do a good contribution for the dental education. And for me, it's a very honor to be here, share with all of my colleagues to one of the more important in implantology.
Yeah.
We need to fight against the periimplantitis.
Yeah. Alberto.
And how we can do to prevent periimplantitis.
Actually,
okay.
Actually, the topic that Alberto gonna talk about to us is one of the interesting topics that we haven't had over the past 2 seasons. So, as he said, it's about periimplantitis, but not about the treating, but about the prevention. And as you all know, he's the guy famous especially for the umbrella concept. And I'm so happy that he will open up that concept for all of us today and how that concept help us preventing the problems, specifically on periimplantitis. What are the factors that we need to take into consideration and how it's possible to reach all those goals and key factors by sticking to the umbrella concept. I'm not going to go to the details because the man himself and the inventor of this concept is here with me and with all of you on Hot Seat. So Alberto, before we start, as a tradition, I would like to have your CV for all of our audience, and then I will ask you to share the screen and we will have a discussion at the end. Dr. Miselli graduated in dentistry at University of Central Venezuela in 1980s, and he's a specialist in implantology of ESI, Barcelona, Spain, professor in the Master of Dental Implants at University of Santa Maria in Caracas, Venezuela. He's guest professor at postgrad course in oral surgery at the Faculty of Dentistry, University Central Venezuela. Also guest professor at the ESI Institute, Superior Studies of Implantology in Barcelona, Spain. Also another guest professor chair at the Periodontics Postgrad Panama University and at Maxillofacial Master at Guatemala University. He's, as I told you, the developer of umbrella concept and also one of the keynote speakers of cervical VPI, which I'm pretty sure he will talk about it during the presentation. And also he's a speaker of many implant companies, national and international lecture for theoretical and workshop and hands-ons in implantology and prosthesis and implant supported rehabilitations. Once again, I'm so happy to have you, my friend, as one of my guests, and so thankful that you accepted to join. The platform is all yours. You can share your screen, and I'm really looking forward for our discussion at the end of it.
Okay. Okay. You see?
Yeah, perfect.
Okay. Well, Thank you. Good morning, good afternoon, good night, depending where you are. Here in Caracas is 30 past 1 in the afternoon. It's a cloudy days, but in this picture you see the mountain in my city, Caracas. It's a beautiful city. It's 900 meters over the sea, and the weather is very good. And let me see what happened here. Okay, let me invite 2 minutes to enjoy my country. One of the beautiful natural view of my country from Venezuela. Let me. Okay. Do you like my country? This is the highest waterfalls in the world. Isn't, as you see, is almost 1,000 meters high. Okay. What is this? This is an implant, but what is an implant without biology? Or what is an implant without prosthetic planning? It's just a screw. So we need to know what we need to do against this disease, the periimplantitis, because periimplantitis is a disease we create when we place the implant without in biology, and the prosthesis it follow this mistake. So periimplantitis is our enemy. We need to understand that more than 50% of the patients suffer implant disease, 24% periimplantitis. This is a study in Spain. Cafeses and Sanz and Rodrigo create this article in 2018, and this number is very impressive. More than 50% of the patients suffer periimplanted disease. So, what is the risk of this periimplantitis? We know all this the risk. I don't want to say again, but it's many important to understand how is the patient, how is how is the health of the patient. But which mistake we have done all these years to produce 50% of periimplant disease. In another way, a crown over implant is an illusion that the dentist create to place a beautiful crown, but the tissue around this crown must be the same of the natural tooth. So this solution has a lot of biology beneath it. We we know many materials to create a beautiful crown, ceramics and disilicate, zirconia, but also we need a health tissue around this crown to create this healthy tissue. This is the way. And this condition must be stable through time. And how we can do that? Because if we don't understand the biology to improve the stability of the soft and hard tissue around the crown and the implant through time, it means total aesthetic. This total aesthetic is very important because the patient need a crown. The patient don't need an implant or disilicate or zirconia or titanium. The patient wants a crown to restore the lost teeth or the lost tooth. So I just invented the name umbrella concept because the umbrella concept is a conjunction of concepts that exist in the world literature about the management of soft and hard tissue seen in a three-dimensional way that allow the preservation of the marginal crestal bone, the gingival architecture, and the aesthetic around the peri-implant supracrestal complex, and the stability through time. And the umbrella is like a mind. We need to open to understand what happened. We don't forget the old articles that explain the biology that we start to forget and put them apart. And this is the key. We need to read many years ago the articles that we to understand where is the path to the success. So we need to learn, see, explore, go to the behind the scene to understand what happened in this plant situation. The stabilization of this soft tissue and hard tissue, we need to know, of course, the host systemic condition, the biological width, or the supracrestal complex, biotype or phenotype, implant macrogeometry or microgeometry. We need to know to choose the right implant in the special situation. We need to understand what is the good or the right implant placement in 3D position, the emergent profile, the platform switching is possible, a good provisional to manage the soft tissue around the implant. And after that, we can do with the final crown. The host is very important. We don't forget the host. The systemic condition, the dangerous habits, local predisposition factor, or the triggering factor are very important to start with the right step. And this in this article of Alberto Monge, in a meta-analytical data, suggests that 18% is patient level and 30% are implant level. But what happened with the operator? How rates of operator? The dependent factor of the operator is many. Drill, how you drill, torque, stress on the cortical, implant position, not considering biological width, healing very wide, more than an implant, flap or bone connected tissue regeneration not stable, flap with pressure during the healing, very important, temporary crown, subcritical contour wider than implant diameter, and overloading and trauma. If we compare tooth and an implant, is more or less the same, but it's similar but not the same. Why? Because we have different materials into this soft tissue, and in this article we see many difference. The gingival sulcus in the peri-implant is depend of the material, depend of the design of the emergent profile. The junctional epithelium depend if the titanium is clean or if the zirconia is high polished. The gingival fibers are more circumferential around the abutment of the crown, in the deeper zone, very close to the connection of the implant connection, and the connective tissue in the implant is like a scar-like. Is rich in collagen, but deficient in fibroblast and vascular system, very close to the titanium, okay? And the blood supply is one of the key, is that few capillaries compared to the tissue around the tooth. And this biological width is the enamel junction, or the epithelium junction is almost 2 millimeters, 1 millimeter more than a natural tooth. And this is one of the keys, because we need to create this space. And how many millimeters is the supracrestal complex? In a natural teeth, the dentogingival complex, including the sulcus, is almost 3 millimeters. But in the implant, and I'm going to show you later, is almost 4 millimeters. 4 millimeters is the magic number. And this dentogingival complex in a tooth, in the implant, is a supracrestal complex. In our last article with Nikos Mateus, Ioannis Pergoulis, and myself, we try to explain and to introduce this terminology of supracrestal complex against the new definition in periodontology about the biological width. Okay, in this article is from Barcelona, the group of BORG. They explain that the circular or semicircular fiber are very important to maintain the soft tissue over the platform switching. To obtain this kind of tissue around the implant, the abutment crown complex, we have 3 zones. One is in the deepest zone is a collagen fiber. One is rigid, and the vascularity is poor. Then we have a epithelium junction to attach to titanium or to zirconia, and epithelium sulcus depend how is the emergent profile of the crown. So this implant supracrestal complex, we divide in 3 zones. The deepest zone is the emergent profile, start emergent profile is a support zone because this collagen fiber maintain the tissue around the abutment. Is a lot of connective tissue, but sometimes we can see epithelium cells going deeper, depend of the material of the crown or material of the abutment. Okay. The other zone are in the intermediate, is a transitional zone, has epithelium and hemidesmosome if the crown has a good shape and a good surface to allow the hemidesmosome attached to the surface. The last zone, and not less important, is the conditional zone, and the plaque control zone is epithelium, is a sulcus, and this area start to the protection of the bacteria invasion. That is a very important. This condition zone with the prosthesis or with the crown to protect the invasion of the bacteria, to promote a very easy clean to the patient with the dental technique. Actually, okay. Okay, we obtain with the healing abutment, the stock healing abutment around shape, but we need to create a individualized shape, depend of the tooth we want to restore. This tissue, we can see in this picture that we have many capillary from the bottom to the surface, and a lot of neutrophil between the cells to protect the invasion of the bacteria. There is a little war between the bacteria and the neutrophils to protect the invasion of the bacteria. In this little video, we show the difference of 2 kinds of shape. One in the left is with a custom healing, and the other with an individualized healing abutment with a cervical. And we can see the projection of the tissue to buccal to create a good contour, soft tissue contour around the crown. Katafushi in the 2017 explained very well that the difference when we choose the abutment and the divergent angulation of this abutment. More angulation, we can promote more bone loss around the margin area. If we have the angulation is less than 15 degrees or 0 degrees, we have more space for tissue. So the connective tissue around this abutment close the area to the invasion, the bacteria invasion. In the same article of the Borg, we see in this microscope view the fibers around the hyaline abutment, and more circular than the others. Okay. It's like a fish around, like in this picture, no? Xavier Vela explained very well in this. This is a horizontal view, and the black zone is the abutment, and we can see the fiber around this area to close the gap and protect the invasion, the bacterial invasion. Here in this article is very, very, very important to understand what happened with the fibers when the implant has a platform switching. Ernesto Lee and Oscar Gonzalez wrote 2 articles with 10 years between them, and explain the consideration of the contour of the tissue depending of the length of the dimension of the tissue from the buccal to palatal. And is a very good article to learn, to study, and understand. Okay. We have 2 choices to place the implant. One, subcrestal or subcrestal. What happens when the implant is placed crestally, bone level? If we don't have enough soft tissue, the bone modify by saucerization and start to lose bone in this area and start to show the implant surface. If we place the implant in the subcrestally and we have enough soft tissue, the bone must grow over the platform because we have a lot of tissue, soft tissue and vascularization around the crestal bone. When we start to connect the implant to the crown, we need to know how much space we have vertically from the platform, implant platform, to the gingival contour or the gingival zenith. Okay, if we have less than 4 millimeters, maybe the crown, if we want a aesthetic crown with a harmonic architecture like the natural tooth, maybe we push the tissue apically and we reduce this tissue, and the biology start to create a bone remodelation, and the bone start to lose around the implant. So we need to place the implant 4 millimeters from the future crown zenith or gingival zenith. This is a key to maintain this supracrestal complex harmonic with all the tissue organized around the implant, around the abutment, around the crown. So we need to check, and we can see that if we have less than 4 millimeters, maybe the implant is going to lose bone. And this is the first advice to mucositis or perimplantitis, because the biology need to create this supra-implant complex. Siegman and Monge wrote an article in 2014 how is going to be the emergent profile dependent if the implant is placed lightly buccally, centered, palatal. And from concave to convex depend where is the implant in the buccal lingual view. And here I show with a little draw how we can design the emergent profile of the area of the abutment to create a more soft tissue in a buccal side. But what happens if the implant is subcrestal? This bone over the implant, we need to protect. So our abutment, we need to start a narrower than implant to avoid don't create pressures over this crestal bone. And the cervical contour, the cervical emergent profile must be 1 millimeter or 1 millimeter 0.5 under the gingiva. It's not necessary to create this emergent profile from the platform, the implant platform, because we push the tissue and we push the crestal bone, and the bone start to lose. And maybe we have a retraction of the gingiva, and we have an anesthetic result. This area, a critical contour or plaque zone control or conditional zone, depending how you can, how is the approach. If the approach is biology, is a plaque zone control. And conditional area, this conditional area is to push with the crown, the tissue, just to create an aesthetic approach. So maybe this conditional zone, we push and reduce the distance of the supracrestal complex tissue, and the bone, maybe if we reduce this area, we start to lose bone. So many questions. We have many questions in this point because we need to know if, first of all, that the perimplantitis is a problem with the soft tissue. And the inflammation in this case occur in the soft tissue, and the bone tissue disappear as a result. Okay? Is an inflammation, but what produces inflammation is an invasion of the materials like a titanium or other material, aesthetic material, to push the tissue and reduce this supracrestal complex tissue. So this is an inflammation situation. On the other hand, the cellularization is not a pathological problem. The soft tissue intervenes to produce a physiological remodeling and create room for tissue. So maybe we place the implant subcrestal, but the bone start to remodeling by cellularization phenomenon and stabilize in one point, in one high or depth. And if the implant is subcrestal, we have the opportunity, or the biology have the opportunity to remodel the bone, but the implants stay under the bone. No bone loss around the first millimeters of the implant. So the physiological socialization creates a biological space, or biological space is a supracrestal complex. So what? If we place an implant, immediate implant, and we use a healing abutment with a big angulation degrees, we start to pressure the crestal bone, and maybe we start to remodeling the bone. But if we change the shape or the angulation with an abutment with less angulation, we can create a room for tissue, and the vascularization create a remodelation and remineralization of the bone. And if you see, after 2 years, the bone is over the platform, very close to the abutment. So, is zero bone loss a possibility when placing implant? I say yes, like a Thomas Linkevicius. Is subcrestal implant placement the right 3D position? I say yes. Subcrestal implant placement loose bone? Depend how much supracrestal complex we have. If I have less than 4 millimeters, the bone starts to lose, no matter if the implant is subcrestal. But we have a protection, this 1 or 2 millimeters subcrestal, to remodel bone, but the implant stay into the bone. Okay. Does platform switching preserve the crestal bone? I say yes, because the platform switching create a mechanical step to protect or to against the migration of the collagen fiber apically. 5 years later, this radiography is 5 years later, we can see how the bone remineralized around the implant and very stable through time. When we need to planning implant placement and a crown over the implant, we need to create a prosthetic planning with a biological and prosthetic orientation. We need to know where is going to be the future zenith. And if we know that this is the zenith area, we place the implant 4 millimeters deeper, no matter where is the bone. Maybe the implant must be 1 or 1.5 millimeters deeper from the crestal, subcrestally. And if we don't have bone because we have a defect, vertical defect, we need to create bone with a bone augmentation to reestablish this area to place the implant subcrestally. This area, the supracrestal complex, is very important, and the magic number is 4. Many articles you can see in the literature. I don't invented anything. I just read many articles and understand what happened. Because for me, it's more difficult to explain how we can have a success than how we fail. It's more easy to explain why I fail, okay? But when I have success, we need to understand what happened. And maybe we have lucky situation, but if we understand the biology, we can reproduce this situation in all your cases. Okay. See this article. This case is very important, very amazing, because we placed an implant in 2006. The implant is a internal hexagon. We place a healing abutment, wait for a crown. The crown was made very close to the platform with a very convex emergent profile. And this implant had a machined collar, polished collar, and the bone grow until the area where is the treated zone, the treated surface. Sorry. In 2011, we took an X-rays and see the bone established in the first thread of the implant, and we said, okay, it's no bad. But what happened after, when the patient came 1 or 2 years later? The crown started to lose, and we take out the crown and reshape this convex area to create a concave area and to reduce the divergent angulation of the abutment. So we decrease the over-contour of the subcritical area. We increase in the biological space. We create more space for tissue to create more vascularity in this area and stop bone loss. This concept, many authors talking about the concave subcritical zone, and we see the result of the tissue, more tissue around over the crestal bone, and the crown, the tissue is aesthetic. We restore the papilla, and we see. But this is amazing situation. In 2012, the crown loosening, start to bone, and we took out the crown, reshape, create a little platform switching, and just screw the crown, the toxification, the area with the chlorhexidine, no more than this one. And in 2014, we see the bone grow and remineralize, and that's why for me the platform switching and the concave emergent profile is the key to create space for tissue, soft tissue or bone. We explain in this picture how we can take out, we grinding the ceramic to create more space and create a little bit switch to promote the soft tissue around the abutment. See this case, the implant was placed, healing abutment. We start to see some bone loss, but we continue, we take an impression, create a crown with a very narrow abutment, no angulation, no divergent angulation. And after 1 year, we can see the right in the last X-rays, we can see the bone grow over the implant and remineralize this area. This remineralization is because we create more room for tissue. In the other case, as a tooth with a fracture, we take out the implant, no graft, only a membrane, but we close the area of the socket in the surface with the resin to maintain the under and protect. And we see after all almost 10 months how the bone grow around the implant, but I'm not happy because I see in the distal the bone don't grow over the platform. We place a crown many months later, and this close stabilization create a condition to create bone. Okay. The 22 months later, the patient come with the loosening crown because it was a cemented crown. And what happened with the bone? Grow. And why? If we have a crown loosening and the bacteria, because the crown move more occlusal, create a space from the emergent profile of the crown to the bone and create more bone. So we take out the crown, we re-cement, but we create a cemented screw crown and placed on 11 months later, we continue to see the bone stabilization in the area. And what is the phenomenon here? Is more space for tissue. It's repeated. You see, you see the detail in details from February 2019 to January 2020. You see the remineralization of the bone around it. Okay, in these 4 cases, we see something in common. In these 4 cases, we create, or the biology create more room for tissue, or by the socialization, or because we create the crown emergent profile in the right way. Of course, the macro geometry and the connection choice in the implant is very important. When we decide to place an implant, we have three choices, or supracrestal, or tissue level, bone level, or subcrestal level. But we think in bone, just think in bone. We don't think in tissue, in soft tissue. Because when we open the flap, we can see different height of the soft tissue from 1.5 millimeters to 3 millimeters or more, okay? Which is better? As a Blinkevicius say, more than 3 millimeters is better. And if the mucosa is 3 millimeters, for example, in this case, the implant can be placed at bone level, so sure? But we thinking in a biology, we thinking in a prosthetic approach. If we know where is the cement enamel junction of the neighbor tooth, and we see where is the crestal bone, this area is in a healthy condition, is in this supracrestal insertion tissue is 3 millimeters. If I say that the supracrestal complex is 4 millimeters, we need to know where is the future crown zenith, or zenith crown. We need to design or analog with a wax up, or digital, where is going to be the zenith of these 2 crowns. So in this point, we measure 4 millimeters, and this implant must be placed subcrestally, That's why we decide to place the implant subcrestally. But because we have a prosthetic planning, this is very important, because if we place the implant bone crestal, as we did for many, many years, we don't have enough soft tissue around the abutment, the abutment crown complex, and the bones start to lose, but the implant start to lose bone in the implant surface. So if we have 4 millimeters and we have a bone with a good, very dense cortical, we need to drill and create a space in the area of the cortical with a countersink. We forgot to use a countersink instrument for many, many years. But this is very important because we create a cortical space against the pressure, the stress from the implant to the bone, and create a closed chamber when we place the healing abutment or an abutment to restore immediately. We see this area of no stress. If we help with a PRF block, we increase the angiogenesis and we create tissue in this area. The biology decide what kind of tissue, if it's bone or soft tissue, or both, to create a supracrestal complex in the right way. Okay, if you have a thin tissue, like this case, we have 1.5 millimeters. It's not enough to place an implant subcrestal. And we, using a biological drill without no irrigation, 50 RPM, because I like to don't create a lot of stress in the bone. We place the implant subcrestally, depending where is the bone level of the natural tooth, the neighbor natural tooth, and the implant we place deeper, 2 millimeters, because we need to create a space for the tissue. See this photography without healing without CTG graft, without bone graft, the biology. We help to biology to create the supracrestal complex. Of course, with association, the bone remodeling, but the implant stay under the bone or stay bone level. We create a false papilla with the cervical healing abutment to create this tissue and create a protection in this area. See the design of the crown with the zirconia, very polished. But observe where is going to be the zenith of the crown. It's amazing. No tissue, no attached gingiva, not attached gingiva in this area, no CTG, but we observe. In this case, when we place the implant in the right way, how the mucogingival junction was created, and the zenith of the crown is in the right position. In this sequence of radiograph, we can see the bone was subcrestal, and then implant the osseointegration, the process continue, and we see that the bone remodeling, but never the bone is exposed to the connective tissue. We can see a good remodelation, a good space, more than 3 millimeters of tissue. And this is very, very important to understand that the implant placement is mandatory. It's not, we need to place the implant subcrestal to create the possibility of the biology work and remodeling the bone to create more tissue, more soft tissue. Okay. I want to, okay, just to see that the osteodesification is a good procedure to place the bone into the medullary area of the bone. Very good. And this is we can do a sinus lift procedure through the alveolar bone. We use a Diva implant. It's a special implant with we can place the material through the implant. It's very and first of all, you push the saline water, then the membrane move, and then you can material the osteoconductive material. You can see here. Okay. I want to go very fast because I don't have too much time to finish, but you can see this technique is a very good technique. Maybe in another opportunity we can, but this is the key to create more soft tissue over the using healing abutment and suture the flap, the relaxed flap over the healing abutment. No screw abutment. Healing abutment. We create a space like a tent to maintain the tissue over the healing abutment. And this apical mattress promote to push the tissue more coronally. And after all, we place another suture to close, and the biology start to work. The biology decide how much soft tissue we need, the implant needs, okay? You can see we close all the area. We can see the healing abutment, but we push the tissue over this healing abutment. Okay, it is another case, very with a good big recession and a big infection in the distal. We do many at the same time. We place an implant with a lateral window sinus lift and see the suture around the healing abutment. But we place the implant bone level. What happened here? We don't have a lot of soft tissue. The healing continue. We restore the cuspid gingiva. We reduce the recession, and 12 weeks can start to see the healing abutment. This healing abutment is 4 millimeters. We can see 2 millimeters. It means that the implant is 2 millimeters deeper. It's not too enough. So we need to create more tissue here to create the 4 millimeters. 20 weeks later, the tissue continues stable. The cuspid very beautiful. But see, when I take out when we take out the hyaline abutment, we observe we have not enough soft tissue over the implant. It means that the bone is remodeling and start to lose bone. See, this less than 4 millimeters is about 2 millimeters. And you can see that the bone, if here is the connection, the bone remodelation start and lose bone. That's why the implant must place subcrestal to protect this problem. In other hand, the subcrestal level implant and the repercussion. What happened? We placed 2 implants subcrestal, and this area in the first molar was a GBR here in this area, and we can see the implant must place subcrestal, and we have a space for a clot chamber. We protect with soft tissue the new bone formation, and we see that the cicatrization is very, very good. In the same patient, in the other side, we place the implant subcrestal, and we can see 16 months later, the bone grow over the implant, and of course, this molar must extract because has a big problem with a bone defect, and we extract this tooth and place a good crown in this area. When we have a lot of bone defect, and we create a bone regeneration, a bone with a screw tent, we know that the bone, we read a lot of articles that the bone is going to lose through time. But why this bone lost? Because we don't respect the biological space. We don't respect the supracrestal complex. If you see the 2 X-rays on the right, you see we try here the structure and the abutment. The molar with the we see the final crown, the bone start to grow in the area around the implant, and we continue follow up this case to see that the bone grow. Okay. I don't want to, I want to go here, sorry. And this video is very important to understand what happened with the bone if we decide to place an implant bone level, but with different mucosa high. In the first case, the implant has 1 millimeter of soft tissue. This is theoretically, okay? And when we place the implant at bone level, and when we are going to place the hyaline abutment, we see that the bone loss to create these 3 millimeters of supracrestal complex. If we have 2 millimeters, the bone is going to be lost 1 millimeters because we need to create the supracrestal complex, okay? If we have 3 millimeters, the bone is remodeling just 0.5 millimeters, maybe because the drilling or because the implant has a polished ring around the first 0.5 millimeters. And if we have 4 millimeters of soft tissue, we hope to have 4 millimeters in all cases. The bone don't maintaining without remodelation, bone remodelation or reabsorption, because we have enough soft tissue to promote the vascularization of this injury. In other case, if we have 1 millimeters of soft tissue in all the 4 cases, we have we place the implant bone level, 1 millimeter subcrestal, 2 millimeters or 3 millimeters. And we see in the same, the bone remodeling and expose the surface of the implant. Okay, 2 millimeters of implant surface exposed because we need to create the biology. Need to create a 3 millimeters of biological width. Okay, so the implant bone loss. If the implant is 1 millimeters, the bone loss 2 millimeters the same on the first case, but the implant show only 1 millimeters of this. But the implant bone loss and maybe mucositis and periimplantitis. In the third case, the implant was placed 2 millimeters plus 1 millimeter soft tissue. The bone remodelation move onto the implant platform because the platform is 3 millimeters from the surface. And the bone stabilizes in this area. But if we place the implant 3 millimeters, the bone remodeling until the platform, but after we see a bone creeping to create a natural biological space. So we can see the bone over the implant and very close to the abutment. This is a phenomenon we can see in our patient, and now we can understand what happened if one implant lose bone or not. Okay. And when we place the crown, we can see in these 4 cases the same quantity of soft tissue, but the difference is that some implant has bone around over the implant, or the implant lose bone to expose the treated surface of the implant. The first in the left, we are sure that we start to see mucositis and periimplantitis, and we start to have problem in our office because we need to fix this problem and waste time in our clinic to save our implant. Okay, this is very funny picture because the abutment is the pole, the hand is a circular collagen fiber, very close to the ground, and the junctional epithelium is over. Junctional epithelium and circular collagen fiber depend on the attach of the surface, or the abutment, or the zirconia. These 4 millimeters is very important to understand what happened in the bone. After 5 years, we continue to see the bone over the implant. Socket shield is one of my favorite procedure to prevent the bone loss in the buccal plate. This is one case. Howie and Maurice are my idol. That we see all their cases, and I learn every day to understand what happened. And Miltiadis is my good friend too, and I ask them many things about this technique, and I'm convinced that this is very good. I know that this technical difficult because we need, but if we understand the biology and we have the right instrument, like how we kids, this is beautiful, and we can do this one with a good result. But we ever use a poncho PRF to increase the vascularization in this area. The angiogenesis start quickly and faster, and more vascularity is better for the soft tissue. And see the difference between the delayed implant placement in the left and the right with the socket shield. We see the vertical height of the bone vertical height is the same, but we can see the difference in the delayed implant. We lost bone vertical. In PET, we maintain the dimension of the tissue, and this is very good, not only for aesthetic, but biologically too. Also biology. Okay, this is another case. How we can reproduce the shape of to maintain this shape of the socket with the cervical, and is a good instrument, but I can live without cervical, because I reproduce and maintain the shape of the gingiva with the individualized emergent profile abutment. And you can see how we can choose or symmetrical or not symmetrical healing abutment individualized. You can see the footprint of the gingiva to reproduce a beautiful crown with the papilla and the soft tissue in the buccal side. This is, I think this is the last cases, I'm sorry. Is an immediate implant, immediate loading. We use a cervical to reproduce a healing abutment, individualized healing abutment, but we grind to create a core. We place a block, a PRF block. We see, this is the picture in the day 0 when we extract the tooth and drilling before to place the implant, and after we retire the temporary, we have this condition of the soft tissue. We see a lot of tissue in the buccal zone without socket shield, but we push we stimulate the tissue to create this volume in the buccal side. Okay. You see the result of the healing of the tissue, and we can reproduce a transfer with the same shape of the temporary. So when we place the transfer in the mouse, we can't see any pressure of the tissue. We respect the volume and the shape. And laboratory, when after we take an impression, we see this blue area. This blue area is the subcontour of the temporary crown. We reproduce in the healing abutment, in the transfer, and when the laboratory create a master model, he obtained this shape footprint, and very easy to reproduce or scanning or digital or analog to create a crown exactly as a temporary crown is in the mouth. So when we screw the crown over the implant, we can see the tissue, no pressure in the tissue, and the results are satisfactory because we have a lot of soft tissue in between the platform implant and the zenith, the gingival zenith. What you need to know and to leave to your home. First of all, the implant position is no negotiable. The mucosa thickness is mandatory. We need to create mucosa thickness. The implant position must be 4 millimeter depth from the future zenith. The platform switching is beneficial. Smaller diameter of the abutment. We need to choose an abutment narrow than implant to create more space for tissue. But the zenith decide all. When we decide to place an implant, we need to design the prosthetic planning to decide where is going to be the zenith of the crown. Why? Because we need to decrease the rate of the preimplantitis in our office. If we see this picture, now we know what happened there. We didn't respect the biology, and the biology create the room for soft, but the implant lose bone. This is the final countdown, because we say, okay, the crown is very adapted, the implant, okay. Why the implant lose bone? Why? Because we don't respect biology. Of course, the teamwork is very important for me. My wife is, as many people know, she's a periodontist, and she taught me many things in periodontology, because I am a prosthodontist. And basically, but with her, we understand the biology, we start to place the implant in the right way. Because pink is our new obsession, but my new obsession. She has this new obsession since many years. So, okay. Thank you very much. Thank you for your kind attention. And any question? I hope that we have time for many questions. Yeah. And sorry for my English. Thank you very much.
It was great. It was great. Thank you, Alberto. And now you can stop sharing because it's we can have a little discussion on the topic that you really presented it super well, comprehensively. And you know, it was a great classroom for all of us because you explained every detail. So actually, you left almost no question for us. But I have some comments, and I want to know really your thought about it. You wanna stop share now, or yeah, good,
No, no, no.
good.
Okay. Okay.
Alberto, you talked about the importance of that 4 millimeters, and I remember that we really had so many comments on the post that we had on Facebook, and we compared so many studies, and you showed us these diagrams. So we reached that conclusion that 4 millimeter is the safest area for us for the biological width, for sulcus formation, for emergence profiling, etc. And you mentioned the importance of narrow diameter abutment, the subgingival contour. So I want to know, first of all, about, imagine that we have enough soft tissue height and we chose a narrow diameter abutment. And now it's time to position the margin of the abutment regarding the future crown. Imagine we have 4 millimeter of tissue. Where should be the margin of the abutment? Should we place it at the level of the gingiva, 1 millimeter below 2? Because when we are using the cement retained crowns, we have some concerns about the cement. So I'm not talking about screw retained, but cement retained. Where should we place the margin of the abutment in these scenarios?
Good question. Sorry. When I start my lecture, I say the crown is an illusion. Okay. And how much of this crown must be under the gingiva? Less as possible. Okay. Because we need more soft tissue to prevent the bone loss. So it's like a ovate pontic. If you decide to do a bridge with an ovate pontic, you need to take out the tissue enough to create a illusion of this crown grow from the gingiva, okay? But the distance from the pontic, the bottom of the pontic to the crestal bone is the same of the implant. It's the same, 3 millimeters. If you create a longer pontic, you produce pressure to the bone, and the bone start to remodeling, okay? Because the biology say you need 3 millimeters to soft tissue over the implant. That's why. This is very simple. I think that is a common sense. If you understand the biology, you need to reproduce as a pontic, okay?
And Alberto, regarding choosing the proper abutment, now in the market we have also margin-less abutments, abutments without margins, and sometimes in some manufacturers we have abutments with margins. So some practitioners recommend a margin-less abutments so they can have more intimate contact and very shallow gaps, they can properly insert the crown. So what is your thoughts on marginless abutments, and do you recommend them also, or you see no difference between these two abutments if you select the case properly?
Yeah, is another good question. Why we decide to use an abutment with a shoulder? Because the technician know where is the place to start the crown.
Yeah.
Okay. If we decide to use a straight abutment or conical abutment without shoulder, and when I probe the depth, the implant depth, and I see 4 millimeters, I need to explain to laboratory, please do start the crown 2.5 millimeters, for example, to create the shape of the crown 1 millimeter below the gingiva margin. Okay. And if you like a cemented screw cemented crown, you need to cement. You don't have any mark to, because the laboratory create the crown. Now the scanner can you can draw in the digital image of the abutment. You can see, okay, it's a 2.5 millimeters. Okay, I put this point, and the laboratory start to create the crown from this point. But if you use the abutment with a shoulder, you need to choose the right abutment. For example, now, since I start to use a cervical, I place the implant ever 4 millimeters below the zenith, ever 4 millimeters. So I only buy a 2 millimeters cuff abutment. 2 millimeters. Okay. If it's a concave, much better. Okay. With the shoulder and the crown cement very close to the shoulder, I can see that is the right position.
Yeah.
Because the implant is 4 millimeters down. All my implants in a aesthetic area or in a posterior area, I place 4 millimeters. Exactly. I have any anatomical problem with a nerve or a sinus, we need to change or the length of the implant, or in case of the lower axilla, in the upper, I can decide if I can use a short implant to avoid to introduce the implant to the sinus, or I make a sinus lift, but never use a long implant. Never. For me, 10 millimeters is enough. Yeah. It's enough.
Yeah, good. And speaking of cervical, because at the time of extraction, if we use this system, so it's very easy for us to save the original emergence of profile of the case, and then we can have a duplicate of it in our impressions, and everything going to be stays the same as it was day one. Now let's talk about the healed ridges. Like 5-6 months have passed and we have a flap. In those cases that we want to reshape and remake the emergence profile with the cervical, do you prefer to use cervical system with the flap, put something like an anatomical healing abutment made by cervical and close the flap, let the tissue heal to be formed, or you prefer to use a provisional crown and add by week to push the tissue and shape the tissue? Which way is your preference, as you are a prosthodontist and you're expert in this field?
Okay, as I showed, I use cervical, or for a individualized healing abutment, no provisional. Maybe it's in the posterior area. I don't want to place a immediate loading, and I choose the right shape in the disc of and the mold, the cervical mold, you have many choice. You have three choice: the shape, the position of the implant vertically, okay, and horizontal, buccal, lingual, or distal, mesial, distal. So you need to understand cervical, but when you understand this system, my assistant, I say 4 millimeters, listen, 4 millimeters. No, first of all, internal hexagon, first of all, 4 millimeters, centered, is a large molar. She do a combination and place the insert, is that the connection of the same of the implant, placed in the right position to create 4 millimeters, and she put an abutment with 2 millimeters of cuff, inject the composite, the fluid composite, photo cure. That's it. 3 minutes.
Yeah.
3 minutes. If it's in a fresh socket, it's very easy to choose the right shape because we have a surgical guide to choose which shape is. But if is a edentulous area, I create a flap, okay, and I know this is a central incisor, upper central incisor. Okay, I choose a central incisor, create the healing abutment, device it, screw and suture around the healing. What happened is in this situation? The tissue in the buccal, I place more buccal because there is a healing abutment, okay? And the tissue heal in this position. When the tissue is mature, and the implant is also integrated, I can take out and see the volume of the tissue in the front, and maybe I don't need any kind of CTG augmentation. Maybe not
necessarily,
because we need. I push the tissue in front in the buccal area, okay. And but if I need to another example, another situation, the implant is placed in the mouth, wait the osseointegration, open the flap to the second surgery, take out the cover screw, okay? And in this moment, I decide what kind of shape of the healing abutment I need. I screw, the tissue is more buccal and more lingual, and suture, and I wait for the healing.
Yeah.
For me, cervical is amazing invention.
Yeah, I agree.
Because we need to. I am a prosthodontist, okay, and I need a aesthetic result, but respecting the biology. So if I have a good emergent profile of the crown, and the footprint is fantastic with a big tissue, soft tissue, thick in the buccal side, and papilla, when I take an impression, the laboratory don't need invented anything, just copy. That's it.
Yeah.
Okay.
Absolutely agree with you. You know, Alberto, the topic that you talk about is so much interesting, and I think we can talk about it for more than a day. but I know the time is limited, and I truly enjoyed your presentation. I'm pretty sure all the audience have the same feeling, and I want to really thank you so much for your time and your comprehensive explanation. I truly enjoyed every second of it. Thank you so much for accepting the invitation, and I really hope after this pandemic ends, first of all, we meet each other personally, face to face, and also I'm looking forward to visit your beautiful country, Venezuela, one day soon.
Yeah, yeah. My country is very beautiful, and we have a problem, political problem, and now with the pandemic, you know, all the world is in the same condition.
Yeah.
But I hope this this condition create a, I don't know what's the name, because I think that this virus don't disappear. Maybe appear another one.
Yeah.
We need to, yeah, we need to learn how to live with these pandemics.
Exactly.
Okay, and but we are human. We are human. We need hug.
Yeah.
Our relatives, our friends. Yeah. I don't know. God bless you, all of them, and stay safe.
Yeah, hopefully you stay safe. Everybody.
Sorry?
I mean, hope everyone stays safe, and give my regard and hi to Ana Luis, and hope you all enjoy your days, and hope we meet soon. Thank you so much again for your time.
Thank you very much. Thank you very much. Bye-bye. See you.
Sure.
And I hope to see you very soon. Okay?
Sure.
Bye-bye.
Thank you.